Good morning, everyone. Thank you so much for having me. It's a real pleasure to be here. It's an honor indeed. This is my third trip to Tokyo, and I'm enjoying it every time. I can already tell you that I'll be back next year because my daughter qualified for the Paralympics, and so I'm supposed to check out the town for everybody. But no, it's a great pleasure to be here, and it's really nice to observe the advancement with regards to grade in Japan, and I'm specifically or very thankful to Akiko and Toshio for inviting me back and for the collaboration. So I will speak about grade in general, introduce the topic to you, give a few examples. It is great that there already were these introductory presentations that talked a little bit about the evidence to decision frameworks. I'll start with my disclosure. So I don't have any financial conflicts of interest to declare here. I have a few intellectual conflicts. I'm director of Cochrane Canada, and I'm co-chair of the GRADE Working Group. In general, you've heard a lot about GRADE, and I'm also on the GIN Board of Directors. The views that I'm expressing here are my own, and I thought that I show you very quickly. I do that all the time because it's a bit difficult to know where we are located. I thought to show you where I'm coming from. I'm coming from Canada. We are located right there, very close to Toronto, in a city that is called Hamilton. Yeah, so Hamilton, very close to Niagara Falls. McMaster University is widely considered the birthplace of evidence-based medicine and problem-based learning. And the department that I chaired for 10 years is called the Department of Health Research Methods, Evidence and Impact, and was founded by Dave Sackett, who is also considered the father of evidence-based medicine. So that's where I'm from, and that's where I forgot my jacket. Seriously. So today I will speak about decisions in healthcare and talk in particular about GRADE, obviously, and guidelines, the evidence to decision frameworks for how they are used, and touch a little bit upon how guidelines do not forget the individual and how shared decision making can take place by using healthcare guidelines. And then very briefly, I think through all of that, what guidelines actually can achieve and what they cannot achieve. I use this example many times in the Western world. Still in many countries, physicians who graduate from medical school have to swear an oath or give an oath, the Hippocratic oath that says do no harm. And in reality, for those of you who are patient representatives or come from the patient and the healthcare consumer side, I have to disappoint you because it is impossible to do no harm. The issue is really to do no net harm. In other words, there's always going to be downsides, unfortunately, on a population level that as healthcare professionals we inflict. But the idea is really to do no net harm. In other words, to make sure that at the end of the day, whoever is being treated or cared for is on average doing better. That's unfortunately the reality. And so do no net harm basically means that when we make decisions, we have to balance the benefits of an intervention, how important these outcomes are that we might be preventing, what it costs, and whether or not an intervention or an option is actually doable. And we balance that against potential harms, as I already said, and how important these harms are. Costs always play a role, and whether or not an intervention is actually doable. There is no sense in recommending something if there's nobody in the country who can actually execute that type of intervention. And then by thinking about that, GRADE really comes in by saying, are you actually sure that you know about these criteria, and how much do you know? And in other words, how certain are you in the actual criteria that I just provided there? So at the end of the day, what guidelines and what we are dealing with is, and it was referred to in the context of decision making, is the certainty in the information or the evidence that we have, and how confident we can be in helping people make a decision in healthcare. That's really what this is about. And the ideal tool that has been proposed to do this are healthcare guidelines. And this is a definition that I particularly like because it brings everything together. So guidelines contain recommendations, and these recommendations are systematically developed evidence-based statements which assist providers, recipients or consumers, and other stakeholders to make informed decisions about appropriate healthcare interventions. Healthcare interventions are broadly defined to include not only a narrow clinical intervention, but also procedures, including tests and so on, that include public health and policy actions, or that are founded in public health and policy actions. Here is an example of a clinical practice guideline, something that we developed very recently, and I'm going to focus on two examples that I think demonstrate how far the guideline development world has actually come, and this is one of them. A guideline that we published just last year after a long project with the American Society of Hematology, and this dealt with the management of venous thromboembolism, and it was for prophylaxis of hospitalized and non-hospitalized medical patients, but we did 10 guidelines with them. The basic anatomy is that typically there's a published document. The published document includes a recommendation. So for instance, here it would say, in acutely ill medical patients, the ASH guideline panel suggests using a certain type of blood thinner in comparison to not using them. And then there's a conditional recommendation, as was already described. In reality, a guideline, that's the surface. In reality, a guideline obviously is much more complicated than that simple recommendation. So as I mentioned, I talked about, I will try to dissect what this type of recommendation or a guideline really has as a backbone. In other words, I will try to tease apart how a recommendation like this is developed, and how that, because by doing that, I believe at least, we will be able to help those who should be participating in actually participating. Those are consumers, and Toshi referred to patients and the patient perspective. This is actually critical. As I said, by dissecting what we are doing in order to arrive at a recommendation, by providing the anatomy, I think we are able to help people understand it much better. So as I said, typically a guideline contains a lot of recommendations. What we have tried to do is we've tried to make sure that people now understand what actually influences these recommendations. So in this particular example, which is just my introductory example, the actual guideline recommendation that you would see either on the web or in a printed version is linked to what was just introduced, the evidence to decision frameworks. In other words, a set of criteria that explain the user of the recommendation, how this recommendation comes about. And in this particular instance, the user of the recommendation not only sees the actual recommendation, and I'm sorry for the small print here, but the user also can get into all of the details by understanding, for instance, what the evidence to decision framework, what the judgments of an actual panel were, and what the underlying evidence is. I'll go on about that. So that is kind of what a recommendation nowadays should be looking like. So information, what should be done, the backbone to it, the research evidence, judgments in an evidence to decision framework. But I will, as I will get back to the second example, expand a little bit and go a little bit back in history, how we actually arrived at this particular point in time with the evidence to decision frameworks. So my involvement with guidelines started about 20 years ago in 1999. After I had done some systematic reviews and so on, I had become interested and started working in the field of thrombosis and hematology guidelines. Shortly thereafter, realizing that there were lots of issues in this field, I was lucky enough to start working with the person who in 2000 actually was the founder of the great working group, Andy Oxman. Andy Oxman recruited me to look at how WHO, the World Health Organization, was developing guidelines, because WHO had come under a lot of pressure. But as it was said, it was probably demonstrated that they were not using evidence in developing their clinical practice, in their health guidelines. And WHO as an organization, one of the fundamental tasks that WHO actually has is to develop guidelines. So how could it be that they were not using research evidence appropriately? So Andy invited me to be part of a small committee that would review what WHO and all other organizations around the globe were actually doing. This led to a series of 17 papers. It led to us working with professional societies internationally. I think it had influence on standards that were produced by the Guideline International Network. It led to, in part at least, together with work in various countries, to the Gin McMaster Guideline Development Checklist. And it led to a text that I believe is very influential still in the world, background documents for the National Academy of Sciences Institute of Medicine clinical practice guidelines we can trust document. So we wrote background documents, and essentially this has been considered one of the key texts for understanding how guidelines should be done. And it's pretty straightforward and very sensible. There's essentially 6 criteria that I like to emphasize. The first is, anytime you develop a guideline, therefore I showed you the anatomy, you should be describing how you got to the evidence that supports the recommendation. In other words, they should be based on systematic reviews and the best available evidence, sometimes from randomized trials, sometimes from observational studies. The second is that they should be developed by a diverse group of stakeholders. It was already mentioned that patients should be integrated, should be involved in the development of guidelines and recommendations, but there are many other health professionals that should be involved depending on the topic that is being covered. But coming back to patients, explicitly patient values and preferences should be considered when you develop a healthcare guideline. This is not about us doctors, it's really about the people who are being treated or are being cared for. The fourth criterion is that recommendations should include a rating of both the quality of the evidence or certainty of the evidence and the strength of the recommendation. Therefore, the GREAT Center, the Mainz Tokyo GREAT Center, because that focuses on rating the certainty of evidence and grading the strength of recommendations. The fifth is that they obviously should be kept up to date. That's a pretty obvious criterion. And the sixth is that they should utilize methods to minimize conflicts of interest. Okay. Little discourse. I'll slowly introduce my second example. My second example is an example, very timely example. It's an example from the European Commission. It's a guideline effort that I co-chaired over the last 4 years. It's the European Commission initiative on breast cancer. And it's quite a good example for a number of reasons. One reason is that we just published the paper in the Annals of Internal Medicine yesterday that synthesized the key recommendations. But these recommendations are actually available on the internet. The interface has changed a little bit, but they're available. They are published as they are developed. And I'm going to use one example, as I said, to bring home a little bit what a guideline panel is doing. So, guideline panels, for those of you who have not been involved in either guidelines or systematic reviews or are not that closely familiar with healthcare, guidelines typically address questions that are answerable in form of a recommendation. So we use a format that has been well established in healthcare. It's called the PICO format, defining the population, the interventions, the comparator, and the outcomes. PICO. And with that type of structure, format, it's actually really easy to do a lot of things, including answering healthcare questions for patients. So one of the questions that we addressed in this particular guideline was, In women who are aged 40 to 44 years, what is the impact of an organized breast cancer screening program as opposed to not having an organized breast cancer screening program on outcomes that matter to women, such as dying from breast cancer, overdiagnosis or overtreatment, and false positives? The European Commission, in its previous version of the website, would have then, similar to what I showed you in terms of the anatomy of a guideline, would have made a recommendation at the end of a process that I will take you through. A recommendation that in this particular age group, we should not offer organized mammography screening. We should not offer it. And it made a conditional recommendation. We heard about conditional recommendations based on moderate certainty of the evidence. So the first question that many people would ask is, after you've heard about what the interpretation of a conditional recommendation is, what does moderate certainty of the evidence mean? And I'll use this particular cartoon that we always use to make clear or try to explain what we actually mean by the certainty of evidence or quality of evidence. So this is one meteorologist saying to another, it's my favorite cartoon obviously in this context, saying, I figure there's 40% chance of rain and a 10% chance we know what we are talking about. That's exactly how healthcare interventions work, in a sense. It's about the magnitude of an effect and the actual certainty that we have in this particular effect. That is different from a confidence interval and so on. The certainty of the evidence can be defined as that an estimate of an association or an effect is correct, or actually better, that a true effect lies on one side of a specified threshold or within a chosen range. And in order to make things simple, when we then, you heard the criterion by the Institute of Medicine, that book that I showed you, one of the criteria was that a recommendation or a guideline should include a rating of the certainty of the evidence. In order to make things simple and to work with different stakeholders, we've tried to come up with simple ways of assessing the certainty that we can have in the evidence. So in other words, evidence comes typically from research, not always, but it typically comes from research, and we should be focusing on the research evidence. We ask 6 simple questions. One is, are the research studies well done? In other words, are there limitations in how the studies were designed or conducted? The second is, are the results consistent across the studies when they should be consistent? So same population, same intervention, same comparator, same outcomes. They should be consistent. If they are not consistent, there is a problem and it lowers our certainty. The third question is, how directly do the results relate to our question? In other words, we are making a recommendation for Japan. All the research evidence is from South America. Can we apply this evidence in our context? In terms of the population, the intervention, the comparator, and the outcomes. The fourth is the effect precise, or is it due to random error, imprecision? The fifth criterion is, do we really have all the research evidence that has been, that we should have? In other words, are there studies out there that have not seen the light of day? In other words, are they unpublished? It's a criterion, a domain that we call publication bias. And then the sixth is, without going into great detail, is there anything else that makes us more confident in these results than it seems? So in many instances, in observational studies, we are concerned about confounding and selection bias, but sometimes the effects are so large that that confounding or selection bias cannot explain everything, so that the large effects may make us more certain. Okay, and where's all of this coming from? This is something that GRADE put together in a structured form, but GRADE cannot claim that we invented all of this. There were some really smart people starting in the late 70s. I mentioned Dave Sackett. Dave Sackett was one of these really smart people who in Canada started to think about levels of evidence and assessing the certainty of evidence using specific criteria. It's probably the origin of evidence-based medicine. But these levels of evidence were defined on the basis of study designs, and they then led to certain types of recommendations. So for instance, evidence from randomized trials would lead to a strong recommendation, or that there's good evidence to do something. What GRADE actually did was, GRADE did away with confusion that arose after these original really smart people put these systems together. Because from about 1979 to about 2000, there were over 100 deviations or derivations of these systems. And people had made up their own little home solutions without really thinking about it carefully and deviating from what had been done. So GRADE, as I said, got together 20 years ago as a working group. This was, as I said, around the time that I got involved in guidelines and involved in GRADE. After 20 years of increasing confusion, we in 2000 developed a unifying, transparent, and sensible system for grading the certainty of evidence in making decisions. Big organizations were involved right from the beginning. So for instance, WHO, NICE, CADIF, big government and non-government organizations. And they continue to use GRADE. As was already mentioned, there are over 100 users. GRADE is for systematic reviews, so for bringing evidence together and rating the certainty, for health technology assessment, and for guidelines. Anybody can participate. This was already mentioned a bit earlier. Anybody can participate. I'll get back to that. We have over 600 members who work together. And we've been very productive. We've actually produced publications with, by now, probably way more than 30,000 citations. And we've produced things like a GRADE handbook and an IT publication application that we call GRADE Pro, which is GRADE's official app. And about 8 years ago, I think it was, you showed the slide, Toshio, I forget. I had the idea of creating centers and networks, and we created the first center at McMaster University. And ever since, there has been quite a bit of interest, and we have now many centers and networks in basically all inhabited continents now, which makes us very happy. And there are people really working in all across the globe, and Mainz being not our last approved center, but one of the more recently approved centers, and I'm really glad to be here. And Toshio already showed that picture. Anyways, that's the meeting that I organized in Hamilton, and very glad that some of you could actually attend. It was a great meeting at McMaster University. So I want to come back to GRADE for the rest of my presentation. So you've heard about the evidence to decision frameworks, but this is really one of our key products, right? This is the key product that we've produced over the last few years, which is the evidence to decision frameworks, which contain a lot of information. And I'm going to, again, I'm going to try to dissect this for you to make things a little bit clearer. Okay, so the evidence to decision frameworks include a healthcare question, as I already described, a PICO type of question. We make sure that we know whether or not those who participate in making a decision have potential conflicts. It includes a section on assessment, which are criteria that I will explain a little bit more, that separate out judgments based on research evidence, and any additional considerations that people have will become clearer to you. There's a conclusion section, which includes a decision or a recommendation, as well as why a certain recommendation is made, implementation considerations, things that should be monitored, such as health indicators or whether or not a recommendation is implemented, and how it should be evaluated. Guidelines often lead to research recommendations. In other words, a group sitting together and going carefully through the evidence is in the best position to identify research gaps. That has informed research not only on policy levels, but it's actually informed research by by drug companies, which I think is a good example that there is a lot of collaboration that can take place. And then there's a presentation section that includes how this is being presented to guideline groups and how meetings are conducted. And there's a database of evidence to decision frameworks and decision aids that can be directly developed from that. But I want to touch on two other issues that are quite relevant. One is which criteria you use to make a decision depends on the perspective that you are taking. If I'm interested in providing the best care for a single patient, it is quite different from if I'm interested in providing the best health care for a population. Unfortunately, it's different, but it is different because in the first scenario, cost may not be relevant. If the patient has to pay out of pocket, it becomes relevant, obviously, but it becomes relevant for that single patient. So whether or not I take a patient perspective or a population perspective, if I take a clinical perspective or a public health system perspective, influences the criteria and the type of decision style that I'm taking. And so the evidence to decision frameworks cover that, in that you can go there and say, I'm going to do a clinical practice guideline, but just going to take a professional perspective as a professional society, or I'm going to take a health systems perspective where cost and opportunity cost may play a much, much bigger role. Okay, that's important. And there's also certain ways of making decisions for health in the health policy context. Another criterion that is, or another factor that is important is the type of decision that I'm making. Am I making a clinical practice guideline recommendation, a policy type of recommendation, or is my evaluation of the evidence intended to support whether or not, for instance, an intervention should be covered by payers? So it's another aspect of the evidence to decision framework. And then, as I said, the use of that whole framework is for decision making as a group. Okay, so how does all of that work? How do groups actually end up making recommendations? I'll take you through this so that you understand some of the guideline development, and in particular what GRADE has contributed a little bit better. So typically, a group, we often call it a guideline panel, but it can be any decision-making panel, gets together with a mandate of somebody, a professional society, minds, the government, and so on. The panel gets together and decides on what type of healthcare questions they should be addressing. We use the PICO framework, quite helpful, as I said, for a number of reasons. Most importantly, that group makes sure that these questions are really well formulated. And one of the key things that is particularly relevant for those of you who are consumer representatives is we spend a lot of time on focusing on outcomes, health outcomes that matter to people, not the ones that matter necessarily to the researchers. And the quick way of thinking about this is not everything that is measured is important, and not everything that is important is actually measured in research. So think about that. So we go through exercises and make sure that from a patient perspective or person perspective, we consider outcomes that are relevant for decision making. We then typically either ask or do them ourselves, do systematic reviews or health technology assessments that bring the evidence from single studies or pieces of research together. We bring them together in a very certain way. We call those evidence syntheses, evidence profiles, or summary of findings tables that synthesize the key information from a systematic review in ways that we think anybody should be able to understand them, including laymen's or laypersons or plain language summaries. That includes a rating of the certainty of the evidence and an evidence synthesis, a systematic review, ideally, on all of the factors that may influence a recommendation. Okay? So, in other words, all of the criteria on the evidence to decision framework. And the evidence to decision frameworks will be described in some more detail, but include a number of factors, including how important the problem is it equitable, is it feasible and acceptable, and I'll get back to that in a second. The group then gets together and makes a recommendation on the basis of reviewing that evidence and making judgments on that evidence. Was already mentioned, either strong or conditional recommendation for or against an option, and this is being published in a guideline, such as the type of guideline that I showed you. I mentioned two pieces of research that is not in your handout because these things were just published. These papers were just published literally the day before yesterday. I forget what time it is, but because of my jet lag. But so if you go to the Annals of Internal Medicine, these are two publications that I think really very nicely demonstrate how guidelines are done and how they can be presented. So that just came out, but I will expand on that. I introduced a question to you by the European Commission about whether or not women at the age of 40 to 44 years of age should be screened. And the idea here for you is not to read what is on the screen. The idea for you is to understand how a guideline panel sits together and develops a recommendation. The guideline panel would carefully look at the actual question that is formulated. We would sit together and go through all of this information. Everybody would have that on their own screen. We use WebEx so that people really, maybe a group of 10, 15, or in this case it was actually 25, 30 people, sit together and carefully look at what the evidence synthesis team has put together. The PICO question, conflicts of interest, the background to the actual question is being reviewed. We then look at these evidence to decision criteria that influence the decision. And I already mentioned that to you. Starts with the problem. Is the problem a priority or the baseline risk? So the baseline risk for having breast cancer may be quite different in Japan than it is for some European countries. If we start screening, what are the desirable health effects? What are the undesirable health effects? How certain are we of the evidence? What happens with regards to values and preferences? So how important are, for instance, false positives as opposed to true positives? What is the balance of the health effects? So remember I said do no net harm. There's always benefits and harms, in this case false positives or over-treatment potentially. How much does it cost? What are the resources that are required? How good is the evidence for the resources? Is it cost effective? What happens to equity? In other words, are there any populations that will be disadvantaged if we start screening? Is it acceptable and feasible? Acceptable to the different stakeholders, the women, obviously health professionals, but also the payers and other people who work in the healthcare system. And feasibility has to do, for instance, with the legal context and whether or not you can actually roll out screening. Are the people sufficiently educated who can do countrywide screening? Then, without going into these details, the panel then starts looking at the individual criteria, the research evidence within these individual criteria. I'm bringing back my pointer here. So here's the research evidence, anything else that the panel wants to add, and then the panel makes a judgment, for instance, whether or not the problem is a priority. The panel looks at the research evidence for the desirable effects, and again, the panel then makes a judgment after reviewing the evidence carefully whether or not the desirable effects are large, moderate, small, or trivial, and so on. But this is being done just to emphasize after reviewing evidence carefully. This just tells you how many studies were considered. You know, how good is the evidence that is out there and how large are the effects, as I already said, would be explained in that detailed description. It's not something that everybody who looks at the guideline needs to understand, but certainly the guideline panel needs to understand what they are doing. The panel then looks at the undesirable effects. I'll take you through that, makes judgments. Certainty of the evidence, so how good is the evidence, values and preferences, the research evidence about women's values related to the outcomes of screening. We would look at whether or not the effects are more beneficial than harmful. In this particular case, the panel, after looking all of this, said, you know what? It looks like there's probably not net benefit. In other words, there's probably it's probably better to not screen women with regards to health outcomes. The panel would look at the resources that are required, hopefully on the basis of research that has been synthesized. Again, how good the resources, the evidence about resources is, cost effectiveness, make judgment, equity, acceptability, and feasibility. But you see here that, just to emphasize, that the panel would look at research evidence for this or information that panel members contribute and then make a judgment together on each individual criterion to, at the end of the day, arrive at a recommendation. This looks like follows. We call this the conclusion grid or the summary of the judgments. So what we see here, this is you have that printed, obviously. You see here the individual judgments of the panel, judgments here of the panel on the individual criteria. And if you look at this carefully here on your printout, you know, everything kind of pointed against screening or suggested that screening would probably not be as good as the alternative, which was to not screen. So that for this particular topic, based on this careful evaluation, the individual judgments, the judgments are important, I'll come back to that. The panel said for asymptomatic women with an average risk of breast cancer in the age group of 40 to 44, this guideline development group suggests or recommends against making a recommendation. It's a conditional recommendation with detailed explanations because you can imagine how contentious that topic is. And indeed, most recommendations are conditional recommendations. They are conditional upon individual circumstances. We think of it like a yellow light. It doesn't exactly tell you what to do. You have to think, am I going to stop or am I going to continue? So conditional upon circumstances, and these type of recommendations need more help with implementation. So for instance, in the case that I just described you, there may be some women who would want to be screened. And these conditional recommendations also help us think about individualization of recommendations. So at the end of the day, despite the fact that we use evidence from populations, many people, we are at the end of the day focusing on the individual, this being Mona Lisa, obviously. And you know, you rarely hear people talk about personalized medicine in the context of values and preferences. In other words, what people think about the outcomes that are affected, so how important the outcomes are. We typically talk about personalized medicine in the context of genes, right? But personalized medicine very much is affected by individual values and preferences, and these conditional recommendations help us often with personalizing or individualizing choices. And this is the way that this can particularly work. So if you think of these evidence to decision frameworks, typically the information comes from populations, but in reality, we are making, at the end of the day, on the basis of a recommendation, such as that recommendation, an individual choice. And that individual choice is primarily affected by a woman's views or a person's view on the benefits and harms, the values, as I said, and for instance, if they have to pay for it. Those are the key factors for an individual. Remember, I talked about, if you take a clinical perspective, population perspective, all of these things are quite important for decision making. So for the individual, we then look at, you know, what is the baseline risk of a person? So for instance, a woman that would want to be screened, what are the values, how important are the outcomes, and that then leads to that individual choice. So that in order to facilitate this choice, coming back to our guideline, there's ways that we present the information as a guideline panel to women or people or patients that may be different from how we present it to clinicians. So a quick example, for instance here, this may be a patient version of the actual recommendation. that the guideline panel made in order to support decision-making by an individual and individualized decision-making. Decision aids, in particular, that was already mentioned for conditional recommendations. So this being an output that can be directly derived from the Grade Pro tool, a decision aid that describes the information with background, the problem, supporting women at different age groups to understand the information that the guideline panel actually looked through, a presentation of the actual results in ways that different stakeholders understand it, and then, as I just said, explanation of the actual outcomes that were considered for women in women's language. So these are marker states or health outcome descriptors. Here, for instance, what does overdiagnosis mean, so that actually women can make decisions around that. Then value assessments that can be integrated. And at the end of the day, a decision support tool that can help a woman say, okay, I want to make my own decision. Well, I'm still not completely clear. Tell me what I should be doing, or I'm just going to print this out and go and talk to my healthcare provider. Okay, so I'm coming to the end of my presentation with one important thing that I already mentioned. I talked to you about how these judgments on the evidence to decision criteria are made transparent and are made by the group on the basis of the research evidence. This is actually a very fundamental change in how we think about guideline development. And it gets back to what Toshio said a bit earlier. You're looking at guidelines and you're using the agree tool to see if you can use them in Japan. Now, what we found in our country evaluations is that just taking the guideline and assessing it for its credibility is not always what helps you with implementation at the end, because there's typically contextual factors that you need to consider. And these contextual factors all fit into the evidence to decision framework criteria. These contextual factors need to be considered in order to really know if this is the right recommendation for Japan. So the agree tool helps you with saying the guideline was well done, but if it's really the right recommendation, requires considerations that are all captured in the evidence to decision criteria. That's actually quite important. And only if you know what the original guideline developer actually thought in terms of the judgments will you be able to say, I agree with this. Okay, this looks the same in Japan. Or, more importantly, by looking at the research evidence that was considered, will you know if you should be looking for local or contextual research evidence from Japan, because it may alter the judgments or it may alter the research evidence. So that's quite important, and I'll get back to that. So in the ideal world, when you use the agree tool to assess the credibility of guidelines, in the ideal world, you actually have the information, all of the information that would be in an evidence to decision framework, because that would make your life easier to use a guideline. This is why I took you through all of this, to use the guideline in Japan. So as I said, the evidence that we have suggests that people in a country that will adopt or adapt a guideline want a little bit more than just knowing if the guideline was well done. They want to participate in implementing it. They want to participate in vetting it or saying, yes, we can use this. So and the evidence to decision frameworks actually allow you to do this. So first of all, I go back to this. So the evidence to decision frameworks, just to summarize what I've talked about, they help you with making the process, structuring the process. Okay, they make recommendations more trustworthy when they are actually applied. So I talked about that. The next thing that I talked about is that if we were to share information that is within an evidence to decision framework, they help us with collaboration and, for instance, updating of information. We now have a few examples where one group prepares an evidence to decision framework, it goes to the next group, they make it publicly available, and then it can go to the next group and the next group, and they can make the recommendation, and international collaboration is actually doable. And few examples, there's just a project that we're starting with WHO in the field of tuberculosis, for instance, where we're specifically working with countries. And so if you think of that, then you can, in your country, adapt or adopt recommendations. There's a framework that we've developed that is called Great Development that supports all of what I just said, that is this adaptation and adoption of recommendations to specific circumstances. The evidence to decision frameworks also help, as I already said, with creating these decision aids for decisions that are patient preference, for instance, sensitive, or where patients really need to think very carefully. And just a pledge, so with regards to the breast cancer screening guidelines, as you see here, they are now adapted or adopted across a number of different countries in Europe. They have been now adopted or adopted really in Tunisia. It's going to start in China, and there's opportunities certainly to do that in Japan, because that evidence, as you, Toshio, as you said, that evidence will be made available by the European Commission, right? So that evidence is there, it's publicly available, and it can be shared. So that really is my final slide. I stop here to give some time for questions and answers, but think of it in the bigger context. Evidence to decision frameworks, that's what I talked about, can make the process very transparent. There's ways of rating the certainty of the evidence that I talked to you and took you through, talked to you about, and then at the end of the day, making recommendations that are transparent and implementable. I'm just going to quit here, because that way we have a little bit more time for questions. Yeah? Yeah, that's good. Okay, thank you very much.